All of you are here because you know Dr. Leibowitz will be here to speak to us. For many of you, he is your doctor. I know he sees many familiar faces in the audience. He's my doctor and has my prostate cancer doctor and has been cancer doctor and has been for almost a decade now. His reputation within the medical community has been hard-earned, but it's well-deserved. You know he has challenged many established treatment plans, and quite possibly he has done more to help more patients, both directly and through his influence, than any other doctor treating prostate cancer. He is just back a couple of weeks now from giving 4 formal lectures to doctors, researchers, and the press in Germany. Had you been there 2 weeks ago and understood German, you could have listened to him at the time. Intellectually, theoretically, and in practical applications, he remains a true world leader in the treatment of prostate cancer. All of you have heard of him. Many of you have heard him. If I may please, Dr. Bob Leibowitz.
Incredible introduction. That's some of the nicest words that have ever been said about me. And can I have the draft back after you read it perfectly? Okay. Originally, I wanted to talk about 3 main subjects, and that is something that I started with, triple hormone blockade as sole treatment for clinically localized or so-called early-stage prostate cancer. But I also want to talk about an anti-angiogenic cocktail that I've kind of developed beginning around last November. And finally, something that I think will stir your interests, testosterone and prostate cancer. The higher, the better, question mark. And I'm curious if for anyone, any man who had a diagnosis of prostate cancer, at the time of diagnosis, would you prefer to have a low testosterone or a high testosterone? And when I asked this in Germany at all 4 lectures, everyone, like 95%, said they would prefer to have a low testosterone level when they were diagnosed. So we'll see if we have some information on that. And I thought that there are 4 major areas to talk about in prostate cancer. Triple blockade as primary treatment, chemotherapy to use for patients with metastatic disease or those who failed local disease or high-risk local patients. This anti-angiogenic cocktail, which we've seen nice responses to even if chemotherapy doesn't work, and then the newest and most exciting about testosterone. So because of time constraints, I'm going to show you just a few slides on chemotherapy and not get into details of it. An editorial appeared this year that talked about MCIT and Taxotere being the new standard therapy for prostate cancer, hormone refractory prostate cancer. And I've actually been using a combination Taxotere, that's the T, MCIT, which is a pill, Decadron, which is a pill, and carboplatinum, which is intravenous. And it's given 3 weeks in a row on. For example, if tonight's Tuesday, if you were getting a dose Tuesday today, you'd get another dose next Tuesday, another dose next Tuesday, and then a week off. And we do that usually for 12 to 18 doses, depending on the clinical situation. And everyone who's on treatment for hormone refractory prostate cancer, they're all on Lupron or Zoladex, and they're on the other hormone blockade agent they're on is never Casodex or flutamide or nilutamide. If a person is hormone refractory, they've already progressed on other hormone blockade. So we always use either aminoglutathamide or ketoconazole. We're not going to have time to go into it. Everyone is also, of course, on Proscar. Everyone is on a COX-2 inhibitor, such as Celebrex, and everyone is on either Iridia or Zometa. In addition, almost all are taking 1 thalidomide a night. And we'll show some slides later on that. Well, Dr. Beldergren, who's UCLA, said that hormone blockade offers only temporary palliation, temporary relief, and all patients eventually progress to hormone-refractory prostate cancer. This progression eventually develops in all cases during the course of conventional and intermittent androgen blockade, leading to death within 18 months with no real chance for getting better with any second or third line chemotherapy regimens. This is like a death sentence. And the good news is he doesn't know what he's talking about. So this is kind of the theme tonight. Prostate cancer treatment biases is nothing sacred, because we're going to challenge all of the concepts, virtually all the concepts you've ever been taught about prostate cancer. For example, this gentleman, 1991, had a Gleason 9, a PSA of 136. He had positive lymph nodes, Lupron and flutamide for 5 years. Then he had an orchiectomy. And that was in 1996. His PSA was 18. In April of 98, his PSA was 128. He came to see me. He had bone metastases on bone scan. So he had already progressed on all the hormone blockades. And he was treated with Taxotere, MCIT, Decadron, carboplatinum, beginning right here, April 98. And he went off chemotherapy in September 98. And we had a little bargain, this gentleman, Tom, and I. I said, Tom, we're going to treat you. In those days, I was treating once a week rather than 3 weeks in a row on and a week off. I said, Tom, as soon as you get a side effect, we'll give you some time off. Well, he never had a side effect. And his PSA went down virtually every week. Now, what's instructive here is no matter how low they tend to go, you almost never get a PSA to go to 0 in someone who's metastatic hormone refractory. Your goal should not be 0. Your goal should be convert metastatic hormone refractory prostate cancer into a chronic disease you can live with. Sort of like high blood pressure or diabetes. You take a little medicine every day, you do fine. So we stopped his chemotherapy in September 98, and he was on a number of different hormone regimens and nothing aggressive. And it took until December 2001 before we had to treat him again. So he was off chemotherapy 39 months. So anyone who says you take chemotherapy, you feel terrible, you lose your hair, you throw up, and then you die, that's just what Dr. Beldergren said in his slide. There's nothing that works. And when we retreated him with chemotherapy, his PSA December 01 and his PSA in June was 5. And he's off chemotherapy again. And this is a gentleman I've shown to you guys before. He was 52, Gleason 8, February 95, PSA just under 2,400. He had metastases to his lungs and his bones. And I treated him at that time with just hormone blockade. Today I would treat him different. When he needed a second cycle of hormone blockade, I also gave him chemotherapy. And he was then off hormone blockade for 17 months and off chemotherapy for 34 months. And he had to be retreated over here, October 2000. So he was treated from October until April, and his PSA was unmeasurable. So now we had somebody in April 01 who's off hormone blockade and off chemotherapy. And his testosterone wasn't recovering real quickly. So I gave him some testosterone. And his testosterone is 600, 652, and his PSA is 0.2. Now this man still has a prostate gland. And with this high a testosterone, it's stimulating some of his normal prostate gland cells to make PSA. So this is now 7.5 years from the time he presented with bone metastases and lung metastases, and he feels 100% normal. He told me he's swimming 100 laps a day in a swimming pool. So this is the disease that they say that you can't treat. Well, in fact, what we've found in our practice is that more than 95% of men that we treat have their PSAs go down, and about 60% have their PSAs drop by at least 90%. So there's lots to do. In the interest of time, I'm going to skip over all of the hazards and dangers of surgery and radiation, except go into a couple of points here. When I first started coming here, and I remember Bill Dean saying many years ago, God rest his soul, he said, I presented my data on triple blockade and my theories and the relatively few patients I treated. And I remember him coming up to me and saying, Bob, I hope that you're right. I hope that this stuff works. Well, out of respect for Bill, or in honor of Bill, I should say, I'm here to tell you that it works great. And in fact, it has made such an impact, this notion of don't do surgery, don't do radiation, don't do seeds, don't do cryotherapy, that it was reported that Mayo Clinic set up a website for early stage prostate cancer, common treatment options. Look, we made the list. Hormone blockade, common treatment option. And an article came out that said, are clinicians providing information about all treatment options to their patients? For example, if you go to a urologist, he's going to talk you into having a radical prostatectomy because he's going to bias his discussion to you to lead you to believe that that's the only thing that can work and there's hardly any side effects. Are men truly informed of the potential risks of incontinence and impotency, as well as the lack of proven benefit? I don't believe there's a guy in this room that was told by his urologist there's a lack of proven benefit for doing a radical prostatectomy. And this study showed that they had information that the types of treatments that are discussed with the patient, if they include only the aggressive treatment options, that's what the patient's going to choose. And of course, surgery has all kinds of problems with it. This is kind of an interesting slide. This is a urologist. Our results imply that tumor cell spillage at the time of surgery may be responsible for recurrence or spread of cancer. Well, I believe it's probably an old wives' tale that if you cut into cancer and expose it to air, it causes it to grow faster. Well, they're saying that they believe it's actually the cancer cells that are spread at the time of surgery. So it's not the air. And I've speculated before and explained that when a wound is trying to heal, trying to grow together, the body releases certain growth factors. And these growth factors cause those tissues to grow together, but the same growth factors may stimulate cancer cells to grow faster. After radical prostatectomy, impotence is immediate. After radiation therapy, it takes longer for impotence, erectile dysfunction to come on, but ultimately 85% have erectile dysfunction. And after radiation therapy, testosterone levels drop by about 30%. So you're not only at risk of osteoporosis, you have a low testosterone level, which later we'll find out is that good or bad. Another side effect of radiation is that it destroys bone marrow, and it reduces the possibility of certain chemotherapies being able to be given because of low blood counts. This was a fascinating slide. Stamey was a urologist at Stanford, and he said in men with stage A and B, T1, T2 prostate cancer that are untreated, it takes the average PSA doubles in about 4 years. But following surgery or radiation, for those guys who aren't cured, the doubling time is usually under 100 days. 4 years to 100 days. So thus it is feasible that the surgeon who creates a positive margin, cuts through cancer, and leaves the edge there, is the same as the radiation therapist both convert a slowly progressive cancer into a rapidly advancing malignancy. Now, what about brachytherapy, seeds? They've become so popular that there will probably be more brachytherapy treatments in 2003 than radical prostatectomies. Well, guess what happens when you put lots of sticks into the prostate gland? You get bleeding. And this study in urology from this year showed that a substantial percentage or number of patients undergoing seed treatment have iatrogenic, that means the doctor causes it, spread of prostate cancer cells in their bloodstream caused by the insertion of needles in the prostate gland. We've talked last year about seeds migrating. 32% of men have seeds show up in their lungs or other places. And radiation seeds have been associated with an increased risk of leukemia and lymphoma, but that's not common. But grandparents or grandfathers are advised not to let their grandkids sit on their laps after the seeds are put in for a while to avoid any risk of radiation damage to the grandkids. So what are we left with? We're finding out that seeds can spread cancer cells, surgery can spread prostate cancer cells, and Paul Lang, urologist in Seattle, the argument that prostate cancer is a systemic disease. Systemic means it's not just in the prostate. It's already left the prostate either before the local treatment or as a result of the local treatment. So the argument that it's a systemic disease is gaining ground from a variety of sources. The good news is you heard it first here in 1993. Dr. Chodak is a urologist at University of Chicago. Some patients choose this approach, hormone blockade for localized prostate cancer, because it helps the PSA. Well, in fact, on my protocol, everyone we treated, PSA went to unmeasurable levels. And because none of the local therapies has been shown to prolong survival. These are urologists admitting this. Journal of the National Cancer Institute, March this year. During the last decade, physicians have begun to treat men with asymptomatic early-stage prostate cancer with hormone blockade alone. And in fact, in a study from 1995 to 1997, 37% of men chose hormone blockade as their only treatment. And I'm reminded by something that David Beyer said, who is truly the pioneer, is that some prostate cancers spread early, and in the future, some systemic treatment, hormone blockade, should be used in addition to or instead of surgery. And he said that in 1981. And only in the last year or so have I seen in print. In fact, it started with another article in the Journal of the National Cancer Institute in November. I was in my office reading late at night, and I opened this article, and it said this, we made these statements about hormone blockade being an appropriate treatment option, and I started yelling and clapping. We'll talk in a little bit about triple hormone blockade, but it's important because this came up especially in Germany. In Germany, triple blockade meant treating with 3 drugs, but any stage. Triple blockade, as I use it as the Leibowitz protocol, consists of 13 months. This was the article that we published. But it consists of 13 months of Lupron or Zoladex. When you take Casodex, it's 3 a day, not 1. And anyone who says they're on my protocol on 1 Casodex a day is not on my protocol. And similarly, they have to be on Proscar while they're on therapy, and then, as of now, Proscar indefinitely as Proscar maintenance. And what's key is it's not called my protocol for men who have previously had hormone blockade or local therapy. And that was what's happened is you might hear, Leibowitz's protocol didn't work in someone. It's not the people who were untreated. Those, it works great. It's someone who had local therapy before or somebody who previously had hormone blockade. Some of you may know that prostate cancer is now divided into low risk, intermediate risk, and high risk, but I'm not going to spend time discussing it. And this is kind of an interesting statement. The more I read, the more patiently I think, and the more anxiously I inquire, the less I seem to know. But what's exciting for me is that hormone blockade alone is now recognized as an appropriate treatment option. It's taken literally 10 years from the time I first began to recommend this, triple blockade, as sole treatment for localized prostate cancer, for an author from the National Cancer Institute to agree with me in writing in a prestigious journal. So that's kind of exciting. So what can we expect from triple hormone blockade for clinically localized prostate cancer? Well, here's a low-risk type patient. In March of '97, PSA 6, Gleason score 6, 13 months triple blockade with 3 Casodex a day, and his testosterone 700 or so. PSA went up to 3.21, and according to some experts, if you're on Proscar and your PSA is 2.5 or higher, you've got to go back on therapy. But I don't agree with that. In fact, I authored an abstract that was published this year that says there is no set PSA number that requires you to go back on hormone blockade. Don't set arbitrary numbers, because look what happened with no other therapy. And his PSA's nice and steady, 2.4 in September '02. So you have 5 years and 7 months follow-up. Guy's completely normal. Another gentleman, this guy had a Gleason score of 7, a 4+3, and PSA 21. He was treated through September '99. And when he went off therapy, by January '01, his PSA was 6.2. But if you put that in perspective, it used to be 21. And he still has a prostate gland. Aren't men entitled to have a little prostatitis? Or you know from before you were diagnosed or friends were diagnosed, PSAs often jumped around. So we just watched him. And in January '02, PSA of 4. No extra treatment, no thalidomide, no iridia. I think he's now on Celebrex, but just about everyone in our practice is. And his PSA, as of a week or two ago, is under 5. And another example, a Gleason 5+3. Today, we would treat him more aggressively. PSA 16, presented more than 5 years ago. PSA got up to 7 in February 2000. Again, when it hit 5, I think every other prostate specialist would have retreated him. He wasn't retreated. He got up to 8 3 times in a row. And now it's 5. This was a guy that was kind of scary for me. Young man, 57, Gleason 6, PSA 7. He should have done phenomenal. February '99, September '99, October '99, up to 5.8. And he was treated through until May. So he already climbed that high. And we continued to follow him. He went down for a while. We were feeling good. Then he went up to 9. And his original PSA was only 7. Now, this is a patient who's symbolic of a number of men in my practice, because I put out a list of the products that I think you should avoid: soy products, flaxseed, soy, isoflavones, modified citrus pectin, fish oils, unless they're in fresh fish, progesterone creams, beta-sitosterol. And this guy at times would tell me, well, you know, I went to the health food store, or I saw an herbalist, or this, that, and the other thing. Well, he got up to 8, and I told him, get off everything, repeat your PSA in a couple weeks. and it came down. And I had to make another phone call to him in October '01 when his PSA hit 9.68. And he went off everything, and his PSA dropped to 3.17. And that's what I do with patients. I sort of negotiate with them. And look what happened in September '02, testosterone 582, PSA 3.12. And that's what he used to be. So you don't panic with any individual PSA. Nice simple one, 3+3, PSA 7, treated through April '98. He had prostate cancer on both sides of his prostate gland. This is the guy that's like ideal for me, no headaches. PSA stayed under 2, and testosterone 628. This is the first patient that I treated. I haven't figured out how to do the Excel slides yet, so I apologize in advance. But he presented with a PSA 34, Gleason 6, elevated acid phosphatase, was called stage D0. He did not want local therapy. So I treated him at that time for 2 years, but since September '93, he's only been on Proscar. So that's 9 years ago, Proscar only. 11 years with a PSA 34. No local therapy. And this is through April '01, PSA less than 3, everything's great. And then in the rest of '01, in January '02, his PSA got up to 3.94, and he came in. This gentleman has no idea how incredible his treatment results have been. And he said, I guess this only helps for a while, huh? It's 11 years. Only helps for a while. Then it wears off. I said, well, I don't think so, Max. And there's his next reading, 3.01. So I've shown you anecdotes. Now I'd like to show you the results from the first 115 men that I've treated with triple hormone blockade only for so-called clinically non-metastatic prostate cancer. Our average age, 66, distribution like this. I have about half a dozen men in their 40s that I've treated also, but these are the first 115. Baseline PSA, 12.7. Remember, Walsh and others won't operate with PSAs higher than 10. Well, we had 26 men with a PSA higher than 10 and 20 with a PSA higher than 20. They averaged a 34. So these are not low-risk cherry-picked. And in fact, using the most recent definitions of low-risk, intermediate risk, high risk, we had this many low-risk, intermediate risk, and high risk. Altogether, 115 patients. Clinical stages are the same as what you see in radical prostatectomy series. And with an average follow-up of 60 months, our average PSA, 2.39. We started at 12.2 5 years ago. Testosterone before treatment, 376. When you're just on Proscar, Proscar raises the testosterone, 430. And it's interesting, I don't know how many of you subscribe to Snuffy Meyer's Prostate Forum, but in his most recent issue, he talks about Proscar being a very effective agent in prostate cancer. That he believes it's anti-angiogenic, as I've talked about before. And one of the nice things about Dr. Myers, we lectured together in San Diego 3 or 4 years ago, probably 3 years ago. And he came on the stage after me because he kind of didn't want people to believe that you can really treat prostate cancer just with 13 months of hormone blockade. But he said, I never believed Proscar had any value in prostate cancer, but I was wrong, and Dr. Bob was right. So I've commended him, obviously respect him a great deal, and he teaches me things. So what about, did it work in everybody? Well, if I told you it worked in 100% of men, you'd call me liars, which is exactly what they've done, is call me liars. And if you were in the internet stuff, you'd see that, oh, no one gets the same results as Dr. Bob, therefore his results are phony. Well, again, they were treating guys with 1 Casodex and no Proscar, and people who had failed local therapy. Well, we've had to retreat 8 men. And this color are the low risk factors. All the rest are high risk. So of the 8 men who were retreated, only 1 had 1 high risk factor, PSA 36. All the others had at least 2 high risk factors, and 1 had 3 high risk factors. High risk is Gleason 8 or higher, PSA 20 or higher, or locally advanced disease by rectal exam. And this gentleman with a very rare type of prostate cancer, endometrioid, under the microscope it looks like a uterus, does not respond well to hormone blockade. If you have radical prostatectomy for this type, 93% of the time it's out of the prostate. He is our only death from prostate cancer. So we have first 115 men, mean follow-up 60 months, mean PSA 2.39, and published results in the literature. This is a difficult slide to read, but it's intermittent androgen blockade from other authors. And in this category are localized disease. That means patients who were not felt to have metastatic disease and who had not had local therapy. And you have 12, 23, 13, 15, 41, 24, a lot of patients. Well, the average time off hormone blockade. I've just told you that our guys have a 60-month follow-up, 13 months on treatment, 47 months off treatment. So about 80% of the time they're off treatment. Okay? 47 months. Average time off treatment, 8 months, 8 months, 6 months, 24 months, but that was a study of only 13 men. 16, Dr. Strum has 15. And all the rest are under a year. And when you are treated with intermittent blockade, the most important figure is the time off, the percentage of time off. You get hormone blockade, you're off for a while. You get hormone blockade, you're off. But notice with every cycle, this one you're off 53% of the time in the first cycle. Then 48%, 47%, 39%, and 37%. That's leading to hormone refractory prostate cancer. It's obvious. So my approach is 1 exposure to hormone blockade and try never again to go back on hormone blockade. Because if you never go back on hormone blockade, you can't get hormone refractory. Hormone refractory is a rising PSA with a castrate level of testosterone. If you're not on Lupron or Zoladex, you're not going to have a castrate level of testosterone. And I've come to the conclusion, although I believe in intermittent blockade, I never retreat a man with Casodex or flutamide. Because Casodex and flutamide are what I've called the Benedict-Arnold syndrome. Initially, they kill prostate cancer cells, but over time, they start to stimulate them to grow. And you can't predict it. You just can't tell when it's going to happen. So anyone who has failed local therapy and has had prior exposure to hormone blockade and has been off hormone blockade for anything less than 3 or 4 years, I just don't ever treat with Casodex or flutamide. I use aminoglutathamide or ketoconazole. So after 5 years of therapy, 1 death from prostate cancer. That gives us a cause-specific survival of 99.2%. Now, the kind of side effects you see on hormone blockade, there's an increase in body fat that can average 5 to 7 pounds, a reduction in muscle mass. You can get fatigue. The best treatment for fatigue is regular exercise. If you get anemic, Epigen or Procrit. I recommend taking pamidronate, which is Iridia, or Zometa. And if you do, then you won't get osteoporosis from hormone blockade. And I'm recommending Celebrex as a COX-2 inhibitor for essentially everyone with prostate cancer. If you have high risk, remember we had 8 patients that we retreated. So what do we learn? You learn more from your failures than your successes. So for high-risk patients now, we add in 12 doses of Taxotere, MCIT, Decadron, carboplatinum, plus the 13 months Leibowitz protocol. When you come off hormone blockade and your testosterone levels rise, about 1/4 to 1/3 of men will notice breast or nipple tenderness or enlargement. This can be on one side or both sides. Also, when testosterone levels are recovering, it's sort of like a thermostat, you can get temporary increase in hot flashes, but then they stop, completely go away. So if you look at how to treat prostate cancer today, I think triple hormone blockade is the best treatment for localized, so-called localized prostate cancer, because I don't believe it's localized in, for 2/3 to 3/4 of the men, and Proscar maintenance. And I first wrote this in a letter in 1994, talking about Zoladex or Lupron, flutamide because Casodex wasn't available, and Proscar. And it's, time has gone by now and everyone uses the word triple blockade, everyone knows it, and people know about now Proscar maintenance. But I really am the father of this. And even as recently as 1997, Dr. Strum, Scholes, and Tisman wrote, "In the absence of any good science, the responsibility for the decision to use Proscar in the treatment of prostate cancer will have to rest with our patients." So it hasn't been everyone who's gone along with this. An article appeared in the New England Journal of Medicine last month. And Patrick Walsh was just in heaven. He was rubbing his hands with glee. Because this article was an article that was a prospective randomized study of over 600 men. Half got radical prostatectomy, half had watchful waiting. And Dr. Walsh trumpeted the success of radical prostatectomy. And if you read the article, what you find is after an average follow-up of 6 years, the same number of men died on watchful waiting as radical prostatectomy. There was no statistically significant difference. There were more deaths from prostate cancer on the watchful waiting arm. The authors pointed out, though, that you'd have to do a radical prostatectomy on 17 men in order to prevent 1 death from prostate cancer. But they said that figure overestimates the benefit, because these were men who were discovered in an era where there wasn't PSA screening, so they were more advanced when they were discovered. If you discover someone by PSA screening, they have less disease, so they're going to live longer with their prostate cancer. And at the end of 8 years, they came up with 8 years follow-up, that figure of 1 extra person living after 17 or 18 radical prostatectomies. They pointed out that the men who had radical prostatectomies, 80% had erectile dysfunction, and more than 60% dripped urine. So I took those results with radical prostatectomy and compared them to triple hormone blockade, because we're recommending triple blockade, not watchful waiting. We had 115 patients, they had 347. So they had 3 times as many patients. So anytime we see a number in our column, we have to multiply by 3. We had an average follow-up of 60 months, they had 72 months. We had 1 prostate cancer death, multiply it by 3, you get 3, they had 16. We had 1 patient develop distant metastases. Multiply it by 3, you get 3 again. They had 35. We had a baseline PSA of 12. They had a baseline PSA 13. Every patient in our series had a Gleason score. 46 of their patients did not have a Gleason score recorded. And in fact, their pathologist agreed on the Gleason scores only 60% of the time. So we were able to give a baseline Gleason of 6.6. Their baseline Gleason is not given. And they do not report how many men have a rising PSA. Now, those men obviously failed to be cured by radical prostatectomy, but they're not even reported. So it sure seems to me that we really beat them. I like that. This is a list of the products I recommend avoiding: soy, tofu, citrus pectin, flaxseed, fish oil. This is one that a lot of guys take: MSN, MSM, MGN, because somebody writes in an advertisement, boost your immune system. Well, if you take spearmint gum, this is going to boost your immune system. And I can sell it for $30 a month. You can get 5 pieces. I'll write some kind of advertisement for it, and I'll tell you how in animals it stops the growth of prostate cancer cells because the gum makes it so they can't spread. But I mean, we laugh at it, but that's what happens when you read these things in different health letter publications, or even for that matter in life extension. These are informationals to try to get you to buy their products. Just remember that. Okay, here's one I guess I didn't fix. Anti-angiogenic cocktail. Angiogenesis means bringing blood supply to cancer cells. And I've been working on ways to cut off blood supply to cancer cells. I've been following Dr. Judah Folkman's work for about 25 years. I had the pleasure of working with him for 1 month when I was at Harvard back in 1975 or 76. And this consists of taking 1 thalidomide a night. We used to give more. We got nerve damage. But on 1 a night, so far, nobody has developed nerve damage. GM-CSF, we'll talk about that. Interferon or pegylated interferon, pamidronate or Zometa that are called bisphosphonates, Proscar, Celebrex, COX-2 inhibitor, anticoagulation with either a pill or an injection, metronomic cyclophosphamide, we'll talk about, and at times 1 of 2 different antibiotics. So what is our goal? Our goal is to make metastatic cancer be dormant, hibernate. If it's metastatic, you're not going to be cured. And it's the most difficult concept for a man to hear and accept. I have a rising PSA after radical prostatectomy or after radiation therapy. I think I'm going to still be cured. If you accept that it's systemic and just concentrate on controlling it and enjoying your life. If 1 radical local treatment didn't cure you, do you really believe another local treatment is? The cancer's been there all those years, it's not going to spread? We already know that before the first radical prostatectomy, 3/4 of men have PSA secreting cells in their bones. So there's the new approach or paradigm in treating prostate cancer, inducing tumor dormancy. So what about angiogenesis? We know that capillaries are generally 8 to 20 micromillimeters in size, and they're lined by a single layer of endothelial cells. That's what lines the capillaries. But if you took all those endothelial cells in the body and laid them on a flat surface, they would cover 1,000 meters squared, which is about the size of a tennis court. That's from your capillaries. The length of capillaries, if they were all put end to end, is approximately, in just 1 kilogram of fat, is 3,500 meters. So think of the enormous number of cells that represents. Now, endothelial cells, in medical school, we thought they were boring cells that did nothing except support the wall. And in fact, they almost never divide. Less than 1/100% of endothelial cells divide at any one time. Now, contrast, it takes them 1,000 days before they double. And in some parts of the body, like the retina, you don't double an endothelial cell for 5,000 days. The bone marrow, on the other hand, undergoes 6 billion cell divisions per hour and turns over all the cells in the bone marrow every 5 days. But during angiogenesis, endothelial cells can proliferate as rapidly as bone marrow cells. That means they can divide every 5 days. There can be 5 billion divisions an hour. Now, you need some angiogenesis, for example, to close wounds. You have to have new blood vessel formation to close wounds, or a woman when she menstruates. But pathologic angiogenesis is persistent and unchecked. And we've since learned that uncontrolled blood vessel growth causes blindness, macular degeneration. If you think about it, they use laser therapy because there's new blood vessels that are growing. That's angiogenesis. It also can cause Crohn's disease, a type of inflammatory bowel disease, rheumatoid arthritis, solid tumors, solid cancers, and leukemias. And angiogenesis is what permits the prostate gland to grow in benign prostatic hypertrophy. One endothelial cell can support from 5 to 100 tumor cells. Angiogenesis, neovascularized, new vascular blood vessels, is what causes blood in the urine from bladder cancer. It's what causes blood in the stool from colon cancer, and causes blood when you cough in lung cancer. All of that is a result of angiogenesis, unchecked. This is an example of thalidomide blocking angiogenesis. VEGF is a vascular endothelial growth factor. So thalidomide turns off blood supply to cancer cells. Thalidomide is the drug that caused birth defects in the 50s. It was sold over the counter. It caused the little flapper limbs because it turned off the blood supply to the limbs. This is a beautiful slide. This represents tumor cells. And tumor cells are sending out messengers. These are pro-angiogenic factors. These represent endothelial cells that line a blood vessel. And they are sending out these signals and saying, grow. We need nutrition. And these cells are trying to produce anti-angiogenic factors. But between the tumor recruiting some of your own cells, they are winning the battle. Blood vessels start growing towards those tumor cells. These have enlarged now. They produce more growth factors. Here's our friend, the endothelial cell. These other cells support endothelial cells. And ultimately, you have a new blood vessel going right into the tumor. Now, cancer can't grow larger than 2 millimeters unless it recruits blood supply. This is essentially how all cancers grow. What's amazing is leukemia is in the bone marrow. But it also grows because of angiogenesis. It recruits blood supply to it. So in 1998, thalidomide, for the first time, was commercially approved in the United States. It was never approved here in the 50s or 60s. We started using thalidomide at the end of '98, and here's a gentleman that July '97, PSA 18, Gleason 3+4. He had some hormone blockade and then triple blockade through September '98. His PSA got up to 16 in January '01. He didn't want to go back on hormone blockade. We put him on thalidomide, 2 every bedtime, and within 2 months, his PSA dropped 50%. Here was another gentleman who had had a radical and hormone blockade for 27 months. When he went off blockade, got up to 1.03. Today, we would not have retreated him. We would have sat on it. But that was March 2000, and a year later, his PSA was still 50% less than it had been the year before. Same kind of a thing, August 2000, prior seed therapy, hormone blockade in 93, August 2000, PSA 12, February 2001, PSA 5. A gentleman in Florida, he had a radical hormone blockade, did not want to go back on hormone treatment. PSA got up to 1.4, started thalidomide, came down, stopped because of some side effects, restarted, PSA dropped to 0.2. Another patient, radical prostatectomy, PSA 134, Gleason 7, Lupron and ketoconazole for a couple months. PSA began rising in 91, got up to 11, did not want to go back on hormone blockade, went on thalidomide, dropped, went off for a while, rose, went back on, dropped, stopped thalidomide, etc. He's currently taking 3 or 4 thalidomide a week, and through June, PSA 6.86. And he started with a PSA of about 12 in May 99. That's 3 years later. And this is my most recent success. Really nice guy. He teaches endodontiry. December 94 was 53, Gleason 4 plus 3, a radical, PSA 9. He got radiation therapy and hormone blockade. In 99, he had 13 months triple blockade. But again, because he previously failed local therapy and prior hormone blockade, they're not long-lasting remissions. So in October 2000, PSA was unmeasurable, but by January it rose to 5. And 1 thalidomide a day in January. February 2.8, April 1.7, June 0.87, August 0.68, and September, this result just came in yesterday, 0.466 from just 1 thalidomide. And no side effects. He teaches in the school about endodontiry. So it's real important to him that his fingers are normal. It's real important to all of us that our fingers are normal. You don't have to teach endodontiry. So just last month, we had a paper published in the journal Oncology, Thalidomide and Prostate Cancer, Responses to Thalidomide in Patients with Advanced Prostate Cancer. When you're on thalidomide, you need some type of anticoagulation. Thalidomide has been associated with an increased risk of blood clots, especially if you're on chemotherapy. So we use a baby Ecotrin, which is like aspirin coated like an M&M, or Coumadin. And we recommend some vitamin B6 to try to prevent nerve damage. In the anti-angiogenic cocktail, we've discussed thalidomide. That's a nice potent agent. We also use an anticoagulant. This was a study where patients who were found to have blood clots were treated with either 6 weeks of Coumadin, warfarin, or 6 months of Coumadin. And they were then followed over the next 5 years. And they recorded the number of patients who developed any type of cancer. And in the group who was treated with 6 weeks of anticoagulation, 15% developed cancer later, somewhere in the body. Whereas 6 months of therapy, only 8%. Anticoagulants, I believe, have an anti-cancer effect. My favorite anticoagulant is an injection of something called Lovenox, low molecular weight heparin. And there's good research data that this can inhibit tumor growth or metastasis, probably by an anti-angiogenic effect. And the easy way to think about it is, in order for a cancer cell to metastasize and cause damage, it has to get into the bloodstream, travel in the bloodstream to a distant site like bone, get out of the bloodstream and attach to bone. And if there's anticoagulant, pretend it makes the cancer cells sticky and they can't attach. That's an easy way of looking at it. From a medical standpoint, they seem to stimulate cell differentiation, cell maturity. They seem to encourage apoptosis, programmed cell death or cell suicide, and they release certain tissue factors, all of which can help kill cancer cells. Now, if cancer cells only produced one or two pro-angiogenic drugs, then we would just use thalidomide and Coumadin or something very easy. But cancer cells are trying to mutate. They produce different pro-angiogenic factors and then evolve and try to produce others. But there's some interesting things we found out. If you have a primary cancer, let's pretend in an animal model, colon cancer, and colon cancer cells have spread to the liver. That's not liver cancer, it's colon cancer cells in the liver. And while the cancer is there and in the liver metastases, the mice do fine. But if you take the colon cancer out, the metastases start to grow. The primary tumor, colon cancer, stimulated something locally for it to grow, but that's in its own vascular bed, but it can inhibit angiogenesis further away. In other words, the primary cancer is preventing the metastases from growing. How can that be? Well, the primary tumor would need to produce an angiogenic promoter locally, more of it than an inhibitor, but that same inhibitor could circulate and have a longer half-life, so the metastases are inhibited. Promoted locally because the promoter pro-angiogenic things are released locally. The inhibitor lives longer, so it suppresses the metastases. Now, what happens if you take out the primary? When the primary is producing inhibitors, the metastases are going to grow rapidly. And every urologist or radiation therapist has seen this happen, where PSA doubling times rapidly increase shortly after radiation therapy or radical prostatectomy. The primary tumor was producing things that inhibited the metastases from growing. When you have triple blockade, you don't worry about this problem. Now, there's a condition that we sometimes see where a patient comes in and has cancer that's diagnosed somewhere, say a lump in the groin or an armpit, and we scan everywhere. We can't find where it started from. Yet they have spots in their lungs or in their liver or in the belly. They have metastatic cancer, but we can't find where it started from. Could angiogenesis have something to do with this? Well, what if the metastases, can this happen in humans? What if the metastatic deposits produced something that suppressed the primary? The same thing. The stuff that suppresses the primary has a longer half-life. So the primary goes away. The metastases stay. And there is such a condition in humans, metastatic carcinoma of unknown primary. And we have such a patient in our practice. Dr. Tucker takes care of him. In 1999, he was 64, went to UCLA. He had an exploratory surgery after CAT scan showed multiple abdominal and pelvic masses and liver metastases. And he had another laparotomy, exploratory surgery, where his gallbladder was filled with poorly differentiated carcinoma of unknown primary, unknown origin. And if any of you have ever had somebody with gallbladder cancer or know of them, they die usually as fast as pancreatic cancers. Well, he was treated with 4 cycles of two very potent chemotherapies, like adriamycin and something called epirubicin. And in June 2000, there was no evidence of cancer. Now, that doesn't mean he's cured. It means they couldn't see it by scan. And he took some time off, moved to the south of France, but in April '01, he had new masses appear, and he was then treated with 3 more cycles of the same thing, 2 months off, but he had progressive disease in his abdomen and pelvis. He got another cycle, but every time you expose cancer cells to the same chemotherapy, they figured out how to survive. Mosquitoes to DDT. Every time you come back, you kill less of them. And finally, in spite of this chemotherapy and in spite of Taxotere carboplatinum, his cancer cells grew right through it. In December '01, he had enlarging liver, abdominal, and pelvic metastases. Now, he's grown through the 4 best chemotherapies that we have to offer. So there's not a lot of hope that you could give him additional chemotherapy. At least there's not a lot of hope that you'd get a response. So he was treated with prostate cancer anti-angiogenic cocktail. And this dark spot here represents a metastasis in his liver. That's in December '01. In May, look at the size difference, and stabilized in September. This shrunk. Remember, a 2-dimension shrinks, you know, is it 2 cubed or something? So this represented about a 50% reduction in that liver metastasis. And he had another one, 3 centimeters, and by May it had shrunk 70% and stayed stable then. This is air in the rectum. This is bladder. All of this is cancer. 1 inch of cancer is 2 billion cells. This is 3 inches of cancer, but it's a cube. I mean, it's round, it's a mass. And there was about a 70% reduction in 6 months, and then again, stable disease. So all of this doesn't belong there, and it's much smaller then. Another mass, this doesn't belong there, and it got smaller. And this guy looks and feels great. How about the other ingredients in our cocktail? GM-CSF, we don't have time to explain what it is. It's a shot that you take once a day. Eric Small up at UC San Francisco reported results on 13 patients. 12 of the 13 had a reduction in PSA, an average about 32%. In one gentleman, there was an astounding response. PSA dropped 99% and continued to stay down at 400 days. So turns out this also probably works by anti-angiogenesis, and it's one of the ingredients in our cocktail. Celebrex, COX-2 inhibitor, new applications in oncology. There's virtually no cancer that doesn't overexpress COX-2. COX-2 is overexpressed in prostate cancer. If you get some of my earlier lectures, I explain this in more detail. At the Urologic Association meeting this year, in May, they reported on 13 patients with rising PSAs after radical prostatectomy or radiation therapy. 12 of the 13 had a favorable effect with Celebrex, 200 milligrams twice a day. 38% had their PSAs drop. 24% had stable PSAs that previously were rising. And 4 out of the remaining 5 patients, if their PSA doubled in 8 months before Celebrex, it took 24 months for it to double. 3 times longer doubling time. Testosterone levels remain stable. There's also emerging data that COX-2 inhibitors may help to prevent Alzheimer's. Do you have to have the disease to get the treatment? Number of tests you have to do to make sure that you're not getting side effects from the anti-angiogenic cocktail. I realize, I guess, the interferon's not on here, but interferon also has an anti-tumor effect and anti-angiogenic effect. Well, I mentioned that word metronomic. Metronomic refers to, instead of giving high-dose chemotherapy infrequently, you give low, tiny doses often in pill form. And the drug that we're using is something called Cytoxan. I have one patient in my practice that years ago received 17,000 milligrams of Cytoxan over 2 days. The dose in this cocktail is 25 milligrams twice a day. 17,000 to 25 milligrams. I know which one I'd pick. And Dr. Folkman pointed out that cancer cells that become resistant to high-dose, infrequent chemotherapy may still respond to low-dose frequent. In other words, 17,000 milligrams may not work, but 25 milligrams twice a day might work. And I would point out what this urologist said in October 2001. Metastatic prostate cancer is resistant to any form of systemic cytotoxic chemotherapy. Now, I showed you at the beginning of the lectures those guys whose PSAs went from 2,400 to 0, or from 137 to 4, and one guy's alive 7.5 years later, the other 5.5 years later. But urologists say you can't help this disease. I think that the only conclusion you can draw from that is don't let a urologist treat you if you have a recurrence of prostate cancer. They are not oncologists, but this is the attitude that they have, or too many have. So this is the drug, cyclophosphamide, Cytoxan. It's been around for 35 years, 40 years. And some of these drugs not only block angiogenesis, but they also can kill endothelial cells because of the low-dose frequent schedule. And realize that endothelial cells do not grow rapidly or mutate, so they're not likely to become resistant to the drugs. Now, there's 2 different antibiotics that we've also been trying. These don't work by killing bacteria, but they actually help some of the other drugs in the anti-angiogenic cocktail to work better, perhaps by helping with this apoptosis gene, BCL2. It makes it easier for the cancer cells to die. And the antibiotics are Biaxin, which some of you may have had years ago for respiratory infections. And the dose that I just showed is the dose recommended at a cancer meeting I was at last year. The other antibiotic is doxycycline, which is a form of tetracycline, but this is a lower dose than you use for infections. You can get side effects. The one that we worry about is irritation of the bladder from Cytoxan. You can get systemic, like chills, fevers, muscle aches as if you had the flu. That would be from interferon or GM-CSF. But we lower the dose if that happens, and the body develops tolerance. So we want to give the highest dose that doesn't interfere with quality of life. And none of it is high dose. Some people on interferon have reported depression. There have been reports of suicide on interferon. We use a markedly lower dose than is used for any other disease. It's used to treat hepatitis and AIDS and certain leukemias or cancers. How well does the cocktail work? This was a guy hormone refractory. We won't go through the details. Started on the cocktail, and later that same month his PSA dropped in half. And he had failed every chemotherapy that I could think of. This is somebody I think who's here tonight. 66 years old, had a recent 5+5, PSA 7, took hormone blockade for 2 months, radiation therapy, more hormone blockade, got his PSA to 0, but then his PSA rose to 68, had chemotherapy, thalidomide, hormone blockade. His testosterone never recovered very high, only 91. Got Taxotere, got more chemotherapy, and in January '02, in spite of all that, his PSA had risen from 1 to 2.45. So I put him on the cocktail, and he came down to 0.62 in March. I'll show you a little bit later what's happened to him since. Here's someone else in the audience. He had a radical prostatectomy, radiation therapy. After 9 months of 2-drug hormone blockade, PSA rose, hormone resistant. Got more hormone blockade, then got chemotherapy and ketoconazole, but developed bone metastases at that time. And while on chemotherapy at the end of 2001, his PSA rose from 0.08 to 0.48. So he was started on the cocktail. And his PSA dropped within 1 month from 0.48 to 0.08. And in the next and last section, I'll let you know what happened to those guys since. So this is what I would say most characterizes Dr. Judah Folkman, who is the father of angiogenesis. Because I remember in the mid-70s that he told me, Bob, the secret to controlling cancer is turning off the blood supply. Now, I was a hematology fellow at the time, and I pictured him tying off little arteries and veins and things. And of course, he wasn't thinking about that. Now, in 1941, 2 researchers at the University of Chicago, Huggins and Hodge, won the Nobel Prize in Medicine for demonstrating that removing testosterone in men with metastatic prostate cancer resulted in temporary remission of their disease. And all of us have been told over and over and over again, if you have prostate cancer, testosterone is like putting gasoline on the fire. It fuels the disease. You must avoid testosterone. They won the Nobel Prize in Medicine for saying it. And I say testosterone in prostate cancer, the higher the better, question mark. How is it that the risk of prostate cancer increases as men age, but the level of testosterone goes down as men age? If testosterone were uniformly harmful, why does the rate of cancer go up when the level of testosterone goes down? And if testosterone were always harmful, nobody should be on intermittent blockade. Because when you're on intermittent blockade, your testosterone recovers. Well, I think most urologists believe, yeah, you're right, castrate everyone. They should not be on intermittent blockade. So there has to be something to this that is more than what meets the eye. In fact, for men over age 40, levels of testosterone decline by 1 or 2% a year. And male menopause is referred to as andropause, androgens being male hormone. The average testosterone in men can run between 300 and 1400. Some people think the average may be 700, others, but that's about right. Testosterone levels, however, fluctuate widely. They're highest in the morning. They go down as the day progresses. That means they follow a circadian pattern. You normally produce 4 to 8 milligrams of testosterone a day, but only 1 to 3% of the testosterone circulates free in the blood. That's the active part. When it's bound to sex hormone binding globulin, it is inactive. It won't get released. When it's bound to regular protein, albumin, it's still accessible. But the free is what makes up what constitutes the most biologically active. So this is probably more accurate measurement. Now, as men have lower testosterone levels, these are the different symptoms you get. Fatigue, hot flashes, you can get insomnia, obviously sexual dysfunction, weakness. Also, nervousness, depression, impaired memory, impaired inability to concentrate, and reduced overall sense of well-being. Does this not sound like the symptoms men on hormone blockade have? I mean, how many of these symptoms did you guys who take hormone blockade, if you ever took hormone blockade, how many of those symptoms can you say, yeah, I had that? Now, usually you don't have all of them, but you have a lot of them. And a study was done and reported in '99 where they took 547 men, not with prostate cancer. They were aged 59 to 89, and they measured their cognitive function, and they measured their testosterone. And 4 years later, they came back and measured their cognitive function again, mental abilities. What predicted for the better performance was a high level of testosterone in men. Well, turns out I'm not the first to think about giving testosterone to men with prostate cancer. Between 1949 and 1967, testosterone was administered to a group of men in New York, Memorial Sloan Kettering. Now, all of these men had metastatic prostate cancer. And remember, in those days, we didn't have PSAs, we didn't even have bone scans. So our method of determining whether or not they were in remission was rather crude. It was, how do you feel? Do you have any bone pain? We did have a blood test, acid phosphatase, but that wasn't real accurate. So in 1981, these doctors reported their results. I call it old testosterone replacement therapy, or pioneering work. And they treated 52 men with metastatic prostate cancer, average age 66. 34 of the men had hormone refractory prostate cancer in relapse. The disease was progressing. 14 of the men were on hormone blockade, either estrogen or orchiectomy, and were feeling fine. 4 of them had metastatic disease, but had never been treated with anything. And they were given testosterone injections. So what happened to them? The authors concluded that testosterone is contraindicated. That means you can never use it if you have prostate cancer. Contraindicated in any man with prostate cancer. And in fact, this is what the package insert says on all products with testosterone. You may not use this if you have prostate cancer. But then if you look at the article and study it in a little more detail, what you find is that there were 34 men who were progressing already with increased pain and stuff. When they were given testosterone, 30 of the 34 got worse, increased bone pain. That's hardly surprising. 1 out of 4 men who had never been treated had bone pain when he was given testosterone. 3 out of 4 didn't. And in the men who were in remission, or what was thought to be remission, we couldn't measure it real well, not we, them, only 4 of 14 had bone pain. Well, these 14 patients who were in apparent remission, 6 out of the 14 said, gosh, I feel great on testosterone. I have increased appetite and weight gain, and I have an improved overall sense of well-being, spelling error, and resolution of hot flashes. 6 out of 14. And the benefit lasted as long as 420 days. So in other words, they were told, whenever you start feeling poorly or get bone pain, we're going to stop your testosterone. Well, one guy went out to 420 days. And 11 out of 14 men who were in apparent remission didn't get bone pain in the first month of therapy. So testosterone did not add fuel to the fire for those men. And in those men who got worse, all but 2 out of the 35 had prompt response to stopping of testosterone. Their bone pain went away, usually within a matter of days. And anyone who had an elevated acid phosphatase, the blood test that preceded PSA, returned to pre-treatment levels. So why do they say it's contraindicated when you have all this? Because 2 men died. Those were men that were hormone refractory with progressive disease. And one man who had metastasis to a spine, the disease grew, got paralyzed. So clearly it's a dangerous thing to do in somebody who's metastatic, hormone refractory, out of control. And nobody in that shape should get testosterone. But let's look at the relationship between testosterone and prostate cancer. 117 men with prostate cancer, 22% had normal free testosterone, 43% had low. If you look at the men with high-grade prostate cancer, none of them with a normal free testosterone had high-grade prostate cancer. 7 of the 64 with low-grade had Gleason 8 or higher. So high Gleason goes with low testosterone. 30% of men over 65 have low testosterone levels. But in a German study, 71% of men younger than 60 who had prostate cancer had low testosterone. Normally, you only expect 30%. Here, 71% with prostate cancer had low testosterone. So they concluded that elevated testosterone is not a risk factor for prostate cancer. Instead, low testosterone strongly correlates with the development of prostate cancer. Low testosterone. There was a study reported out in the British Journal of Urology this year. 96 patients treated with hormone blockade. They all had metastases, group 1 and group 2. Group 1 mortality at 18 months was 19%. Group 2 mortality at 18 months, 83%. The groups were balanced in PSAs and Gleason scores. The only thing different, group 1 with the low mortality had almost twice as high a testosterone as the group with the 83% mortality. All other prognostic factors were balanced. So when I asked before whether you'd like to have a low testosterone or a high testosterone when prostate cancer is diagnosed, the answer is fairly obvious. Testosterone in prostate cancer, the higher the better when you're diagnosed. Well, another one of my heroes, Nick Bruszewski, showed that, that male hormone has 3 functions. It can inhibit cell death. It can induce cells to mature. When you inhibit cell death, like prostate cancer, that wouldn't be good. But the third function is it can actually turn off prostate cell growth. That's one you don't normally hear about. But what if testosterone only did function 1 and function 2? No prostate cells would die, and you'd keep growing prostate cells. And eventually all men would be prostate glands. So there's built-in something to turn it off. Turns out it's testosterone. And an editorial in the Journal of the National Cancer Institute last year, the 2 faces of Janus. Janus was either a Greek or Roman god that guarded a portal and had a face in front and a face in back, so no one could get in. And the editorial was male hormones, and they also talk about in breast cancer female hormones, as mediators of cell proliferation, cell growth, and cell death. So they can sometimes cause cells to grow, cells to die. And one of the analogies that I use is if a premenopausal woman came to see an oncologist, she's 42 years old, she's still menstruating, she's found to have breast cancer. Bone scan shows metastases, she has bone pain. So she doesn't have bone cancer, she has breast cancer cells in her bones. In the 1970s, the treatment would be remove her ovaries, take away her estrogen, and 60% of the time they went in remission. So estrogens were fueling breast cancer to grow. Well, what if the following week her mother, who's 72, comes in to see you? Mom, coincidentally, has breast cancer, and hers spread to the bones. and she has bone pain. But she hasn't menstruated in 25 years, and she never took estrogen. So you wouldn't take away her ovaries, they're dried up. The treatment for mom, give her estrogen, and 60% of the time her pain goes away. So you take away estrogen from the daughter, you give it to the mother, and it causes remission in both. How can estrogen stimulate breast cancer in the daughter but cause it to go in remission in the mother? That's the two faces of Janus. Hormones inhibiting proliferation and also stimulating it. Now, the ability of a cell to commit suicide and express PSA are acquired as the cell matures. Prostate cancer cells mature, or prostate cells mature, under the influence of testosterone. And there's a there's a prostate cancer cell line in the laboratory where low levels of testosterone stimulate prostate cancer cells to grow, but higher levels induce an irreversible shutoff in the growth of those cells. And the inhibitory effect of testosterone has been found to be due to the AS3 gene. They already found a gene that turns off prostate cancer cells' growth under the influence of testosterone. These findings suggest that the inhibitory effect of testosterone on prostate cancer tumor growth may have the potential to be used to treat prostate cancer. Growth inhibition by testosterone of prostate cancer cells is not a rare and casual event. Testosterone is able to induce cell suicide in some prostatic cells. And there's a biphasic response. Low levels harmful, high physiologic doses can arrest prostate cancer cell growth. And these two effects are dissociated in time. Low growth has occurred first with increasing growth, or low levels rather, of testosterone, and then later you get the inhibition. And androgen inhibition of cell proliferation and androgen induction of cell death provide the basis to consider administering testosterone to select, this part is me, that's not Soto, to select, and I emphasize, very select, very few prostate cancer patients. Low testosterone levels, not enough that they make you feel lousy and take away your sex drive and ability to concentrate. They seem to be a risk factor for coronary artery disease. And my ideal range for testosterone in somebody who's taking testosterone, I'm real happy when it's 1,000 or higher. That's where I love it. And I think this patient is in the audience. In fact, I know he is. 74 years old, testosterone before treatment, low 180, PSA 11, Gleason 6, 13 months triple blockade through November 01. Went off hormone blockade in November 01, but by April, his testosterone was only 70. So we talked about the dangers and risks and whatnot of testosterone replacement therapy, but he said, well, let's give it a try. We'll measure testosterone and PSAs every month. And his PSA, with a testosterone 72, PSA was 0.08, and his PSA rose to 0.47, 0.72, and 1.27, going up kind of quick. And his testosterone kind of stable, 450 to 540. So when his PSA in 1 month went up that much, I said, double your dose of testosterone. I'm sure you would all agree with that. And his PSA did that. PSA had been 1.27, and with a testosterone of 1,095, PSA dropped to 1.08. Anyone believe that? You can go from testosterone 453 to 1,095 and your PSA can go down, and you've had prostate cancer? You're not astounded? I know I was. This is a retired neurologist, and he had a PSA 23 and a Gleason 9. Ugh. Radical prostatectomy, hormone blockade. Then he went on hormone blockade for about, I don't know, 3 years. Then he had chemotherapy and hormone blockade. And December 01, PSA 0.16. And his testosterone was never more than about 250. So, or 300. We put him on testosterone. Testosterone was 311. His testosterone is 1,000. PSA 2.98. Testosterone is 1,000 and your PSA went down? Let me see. Raise your testosterone, PSA goes down. Something doesn't sit right. Have you guys believed it's been different? Have you expected different than this? Did someone tell you that testosterone is always harmful for prostate cancer? Was it the same guy who told you to have a radical prostatectomy? This is a kind of a busy slide. I tried to edit this slide and was unsuccessful. Nice guy, May of '92, Gleason 7, locally advanced, and he went on hormone blockade for 7 years. You've been on hormone blockade for 7 years, your testicles are dead. They're never going to recover. So he went off treatment in '99, and I had trouble. This guy was living in Denmark for a long time, and so his testosterones did this, which I think is dangerous. But most of the time, and this is his PSA, 1.7. That's in January '02. And I said, Victor, you need to have a consistent testosterone level. You have to put it on every day at the same time, use the same product, you have to this and all that. And he finally agreed. And we aimed for a testosterone above 1,000. And I apologize for the next slide. Testosterone is 1,600, and his PSA is under 2, or is 2.2. So he's had prostate cancer for 10 years, was on hormone blockade for 7. Testosterone 1,600, PSA in the 2s. He still has a prostate gland. So I'm hoping all that's from benign. This is a Gleason 8. PSA 11, when he went off hormone blockade, his testosterone it kind of got stuck in the 400 range. When started testosterone, he jumped up to between 1,100 and 1,200. PSA was 1.31 in August. Wonder what happened in September. 0.6. So his PSA was 0.5 with a testosterone 459. And when his testosterone is 1,236, his PSA is 0.6. And guess how much better he feels? I mean, he literally says he feels like a young man again, like he felt in his 20s. And that's his PSA response to high-dose testosterone. Rather remarkable. And he's in the audience. I showed you this slide when he went on the anti-angiogenic cocktail. But then we talked about, how about some testosterone? And this is a PSA of 0.15. And this is a testosterone of 1,200. In September 2002, testosterone 1,200, PSA 0.14, metastatic disease, hormone-resistant prostate cancer. And he kind of told me an interesting story that prior to testosterone, when he tried to work out in the gym and in his garage, he was struggling to lift the weights. But as soon as he went on testosterone, he'd get a true story. Other gentlemen in the audience, I showed you his slide when he went on anti-angiogenic cocktail. In March, his PSA was down to 0.62. Then it kind of bumped around. And I put him on May 2nd. Testosterone was 20. And a week later, 2 weeks later, 734. His testosterone in September, 600, PSA, 0.447, testosterone 754, hormone refractory. He's here, hormone-resistant disease, radiation therapy, went on the cocktail. Testosterone in 1 week went from 20 to 1600. In August, testosterone 1400, PSA was 1.58. Another one, testosterone 20, 1 week later 1600. 1 week. And PSA went down that week. What are the side effects of testosterone? You convert fat into muscle. You can lose weight. Your bone density improves. There's no liver or kidney toxicity. Obviously, your libido improves. Memory and intellect improves. One example, a guy told me is it used to take him an hour and a half to do the New York Times crossword puzzle. Now it takes him 30 minutes. Another guy explained how he always hated bridge that his wife loved. He couldn't concentrate on it. He said now he's a whiz. He looks forward to it. We do have to monitor frequent blood tests when they're on it. And if you're hormone resistant or refractory, everyone is on the anti-angiogenic cocktail plus testosterone. Because remember when they gave testosterone to hormone refractory guys who were in relapse, they all got worse. But when you add the anti-angiogenic cocktail, we're seeing different results. And remember that most men live with prostate cancer and die with it, not from it. And all we want to do, that's our realistic goal. That's what we want. The significant problems we face cannot be solved at the same level of thinking we were at when the problem was first recognized. So 61 years after someone wins the Nobel Prize in medicine for taking away testosterone, I'm challenging that notion. I'm not saying that that's the way to treat even a significant number of men, but I can tell you the guys that are here in the audience who are on testosterone, hopefully they'll agree to talk to you. Maybe, I don't know where we'll have to ask them to stand, but ask them how their quality of life is. They're new men. And I got to tell you, I think almost without exception, their wives thank me a great deal as well. I heard this expression many years ago, and I didn't know entirely what it meant. I thought this was a guy who specialized in Hodgkin's disease. But he says, pick one disease, study it well, and it will carry you to the ends of the earth. And when I lectured in Germany, I understood that part. But what I think it really does is it allows you the opportunity to question pre-existing biases. Don't ever accept, we've always done it that way, therefore it's right. And that's what I think I've done best in my career. Thanks.